Good afternoon, everyone. Thank you for joining us. Today, we are joined by the Wintergreen team. They'll be presenting over Medicare Advantage internal strategies. We are a smaller group, so please feel free to unmute your line if you have any questions or comments or would like to offer any of your experience. Also, I will be watching the chat. If you're watching this recording and if you have any questions or concerns at all, please do not hesitate to reach out. And with that said, Nicole, I will turn it over to you.
Thanks, Laura. I'm actually going to turn it over to John to start us off.
Thank you, Nicole, and thank you, Laura. And I just wanted to second what Laura said there on this being a conversational presentation. We are super excited to share with you today some of our findings and some of the work that we've been doing. And just to give some kudos to my colleagues, Nicole and Jennifer, they bring some awesome expertise, and I'd love for you guys to interact with us, ask us questions as things come up. We'd love to answer and interact with you guys, so please feel free to do so. My name is John. I'm one of the senior consultants at Wintergreen, and what we're going to do here to begin, before I hand it over to Nicole and Jennifer for them to share, we're going to kind of go over what we've talked about so far in other presentations surrounding Medicare Advantage, just to kind of give some of the history, some of the background before we kind of kick off and explore the internal strategies to kind of approach the Medicare Advantage and some of the challenges and opportunities that we're seeing in that world. So just to give some brief overview before we get into that arena. So Medicare Advantage really started to boom back in 2010 when the Affordable Care Act created some incentives around improved quality of care. So that's when we really started to see kind of a shift towards Medicare Advantage plans becoming more and more popular. And between 2009 and 2017, we saw Medicare Advantage increase more than 80%. So we really saw those plans really start to jump in that time period. And that's when we started to notice those plans becoming and providing some of the areas and challenges that we are seeing today. And from 2018 to 2022, that's when we really started to see the private program growing year over year exponentially. And so as we go to the next slide here, we will kind of start to look at the growth that we've been seeing. So as you can see over on the left-hand side, we're looking at that pie chart. In 2023, we started to see the Medicare Advantage actually be the more popular option, sharing 51% of the market share. So we saw Medicare Advantage become more popular than our traditional Medicare plans, right? And as we'll talk today, that becomes really important for us to follow because of the boundaries and some of the challenges that Medicare Advantage, especially in rural health, kind of provides. As you can see here in the blue chart, we're going to see kind of what I was talking before when we started the boom. As you can see here, it's grown every single year since 2007, right? So this isn't something that we're talking about being a new fad. This isn't something that happened a couple of years ago and we're not quite sure what it is. This is solid data showing us that since 2007, Medicare Advantage has grown every single year, especially with the last couple of years being the biggest ones. So this is something that's really, really prominent. It's not going away. And it's something that we need to talk about, especially since it does provide certain challenges, especially in the rural space. Next slide. So what we wanted to talk about here is really kind of showing that based off of 2023 statistics, Oklahoma has between 40 to 50% penetration. So when we're looking at Medicare Advantage, what we saw happen is it really kind of started to be more prominent in some of the larger cities and states on the outside of the United States, right? And what we're seeing now is we're seeing Medicare Advantage plans starting to make its way into rural America in the center of the states. And so what we're seeing here, what we really want to make note of here, is that we don't even think or know if we're at full penetration yet. So if we're experiencing these challenges today and we're not even at full penetration, right? We need to have these conversations and start to plan around, okay, if this isn't going away and we're not even seeing the full penetration that we think that we could see, let's talk about this. This is something that we really can't think that's going away and something that we really need to tackle. So that's what we're trying to really show here is that we're not even to full penetration yet, probably. Next slide. So we did a study at Wintergreen with a couple hospitals in Oklahoma, sample size being, I believe, 5. And what we really noticed here, the important thing to kind of wrap our head around is that there was an opportunity, if you will, of about $6.7 million across those 5 hospitals alone, right? So what we looked at here is we're really comparing and taking a look at, okay, if Medicare Advantage plans should be reimbursing around the very same percentage or around the same guidelines as a Medicare plan, traditional Medicare plan, well, then we should be seeing our collection percentage around the same. Well, if you can see in the first graph there, those last 2 rows, on average, those 5 hospitals, when we're looking, 51% seems to be around the average. So even looking at even using my my time at other hospitals, 51 to 55%, even 50% is around where we see our collection percentage for traditional Medicare. It hovers right around 50. And what we saw with the Medicare Advantage is very typical of what we've seen at other hospitals as well in different states, is that it's much lower, typically in your 30s. We've seen it lower, we've seen it slightly higher, but it's somewhere around that range. It's a big disparity, right? So why are we seeing that when they should be the same? Our collection percentages should be very much the same, and they tend to not be. And this is a great example of exactly what we've seen in other states as well. So why are we not seeing that? And what's the dollar amount, right? So every hospital is going to be a little bit different, but if we're taking 5 hospitals in Oklahoma, $6.7 million being that kind of fall short, it's not a small number. Next slide. So we've talked about in a couple presentations previously around some of the external options, if you will, around how do you deal with the Medicare Advantage, knowing that our collection percentages are not the same. There's a dollar opportunity out there. How do we capture that? What do we do with the Medicare Advantage, right? How do we attack some of the known challenges that Medicare Advantage plans provide, right? The challenge that it provides to our revenue cycle folks with the increased denials, right? The various other challenges it provides. How do we deal with that? And we've talked about the external options, right? Refusing contracts. We've talked about potentially going to our legislative part, right? Lobbying for our hospitals. And today we want to talk about the internal approach, right? How do we understand the challenges that Medicare is providing to your hospital specifically, right? Because they're not all the same, but they tend to be, right? So how do we approach this and try to either eliminate the challenge completely, or at least understand where that challenge is inside your hospital specifically, right? So when we're talking about this, a lot of the time we're looking towards our operational folks, right? Do we have the right people and the right resources to not only understand the challenges, but put forth a plan that's going to make sure that we understand where it's challenging us the most and try to attack and get the reimbursement that we deserve, right? Even though we know it is challenging and it does provide a burden, how do we make sure we have the right people? If not, how are we finding them, right? Who are we looking for? What experience do we need? Maybe it's looking outside of what the normal qualifications or the normal experience, tells us we need. Well, are there other skill sets that we could also look for that might be helpful to our teams, right? And do we have enough leverage to be successful? It's a great question. So with that said, I want to kick it over to Nicole and Jennifer to really talk a little bit more about what other internal strategies and how do we approach this. As we know, Medicare Advantage provides us challenges, and what are some possible solutions that we can implement today to make sure that those challenges that we know are there, maybe solve them or make them better a little bit. And Nicole and Jen will shed some light on that. So thank you. And Nicole, I'll hand it over to you.
Thanks, John. So before we really start talking about the internal management and Medicare Advantage plans, before we dive into some of those internal strategies, I want to take just a few moments and look at the differences between Medicare Advantage plans and traditional Medicare, and what pulls patients towards these plans and how this creates challenges for hospitals and healthcare communities. So since this webinar is all about Medicare Advantage plans, I think we need to understand the differences in these plans. In 2024, 3/4 or 75% of enrollees in individual Medicare Advantage plans with prescription drug coverage paid no premium other than their Medicare Part B premiums. This is a huge selling point for this older population. They are beneficiaries that particularly live on modest incomes and have small amounts of savings. Medicare Advantage beneficiaries also in 2024 spent an average of $2,500 less per year on out-of-pocket costs and premiums compared to those enrolled in traditional fee-for-service Medicare. So how many of you on this call have signed a contract with one of these payers and later found language in the contract related to payment or contracting or credentialing that you were not aware of? The same thing is happening to our patients. Not always do they have all of the information about the plan that they may need, but they may be making a decision based on just that dollar amount alone or an additional factor. As we continue to explore Medicare Advantage, one of its biggest draws is the additional benefits offered to enrollees. So let's break this down a little to understand what these plans make attractive to their beneficiaries. On this slide, you can see a breakdown of the share of Medicare Advantage enrollees in plans with extra benefits. In 2024, nearly all Medicare Advantage enrollees had access to benefits that go beyond what traditional Medicare coverage. For instance, 100% of individual plan enrollees have access to eye exams and eyeglasses, which is a huge need in the population those plans are serving. 98% had dental benefits. And another popular benefit with this beneficiary pool is hearing exams and hearing aids. Some plans even include benefits such as meal plans. While these extra benefits are widely available, it's important to note that the scope of services and coverage varies by the plan. So let's look at those dental benefits as an example. Some plans may cover only those preventative services like cleanings or x-rays, while others might extend services to major services like crowns and dentures. Additionally, plans can differ significantly in their cost sharing requirements and annual caps on what the beneficiary will have to pay. There also is then the provider network issue that the patients must use. This variability can leave a real impact on how much beneficiaries benefit from these extra offerings. Which brings us to a really critical point for both patients and providers, understanding the fine print. Beneficiaries are often drawn to these plans because of the advertised benefits, but they may not realize the limitations until they attempt to use these services. For providers, this also means navigating prior authorizations and network restrictions that can complicate care delivery. Nearly all Medical Advantage enrollees are in plans that require prior authorization for some services, as you can see on this slide. While preventative services are largely exempt from the prior authorization requirements, there are common areas such as high-cost areas that require prior authorizations, such as a skilled nursing facility stay, a swing bed stay, Part B drugs, acute inpatient hospitalizations, and psychiatric services. Even for services such as home health and diagnostic testing, prior authorizations are required for 90% or more of enrollees. Recently, we were working with a hospital and they had an MA plan that required prior authorization on all lab work and specialist visits. This hospital was not aware of these requirements and had racked up a fair amount of small denials due to these clauses. This is a significant distinction between the two programs as it impacts not only access to care, but how quickly that care can be delivered. Here we outline the three key areas of challenges that Medicare Advantage plans introduce. They have increased administrative complexity. Providers face mounting authorizations and documentation requirements, adding to that administrative burden. Frequent denials and appeals further complicates workflows, delaying care for the patients and creating frustration for our staff. There's the impact on the revenue cycle. There's an ongoing debate between observation versus inpatient admissions and the effects of these reimbursements not only on the hospital, but the patient. Observation status often leads to lower payments compared to inpatients for similar care and higher deductibles for the patient. There's patient care coordination challenges. There's network restrictions and referral issues that make it harder to ensure patients receive timely and appropriate care. Managing transitions of care, especially for complex patients, is more difficult due to these limitations and added administrative burdens. These challenges are not just operational, they directly impact patient outcomes. Authorization delays can mean delayed treatments, and the financial constraints can limit resources for patient care. Providers are often stuck navigating a system that prioritizes cost control over ease of access. As healthcare leaders, our goal should be to find strategies that mitigate these challenges, whether it's through better documentation practices, improved care coordination efforts, or educating patients on the nuances of the plan. We can help lessen the burden for everyone involved. Well, I had a poll question here, but for some reason it's not loading, so we're just going to move forward. So we're going to jump into tackling the challenges. So to address the challenges we've discussed, organizations must implement strategic internal solutions. On this slide, we highlight 3 key strategies: prevention, denials management, which is all complemented by contract alignment. So when we talk about prevention, we're really talking about the strategy that focuses on being proactive. We want to minimize issues before they escalate into costly denials or operational efficiencies. With denials management, even with the best preventative measures in place, denials are still inevitable. So we need to have a good workflow to deal with those denials when they occur. And with contract alignment, it's really utilizing claims data to demonstrate the value of care provided in your organization and ensure proper reimbursement for your facility. I'm going to dive into those operational strategies for you. So to achieve success in today's healthcare environment, we really must break down the silos that have been traditionally separated revenue cycle and clinic operations. The challenges we face require collaboration, alignment across teams. And the first step to do this is recognizing that long gone are the days when doctors and nurses and clinical staff only focused on direct patient care. Today, the clinical decisions and financial outcomes are interconnected, and it's essential to build these bridges between these two areas. Consider contract issues. For example, we had a hospital we were working with who their utilization team was doing a really great job of obtaining prior authorizations, but they had one payer who was authorizing for a nursing facility bed and not a swing bed or a skilled stay bed, which impacted revenue largely. But without having that revenue cycle team communication back to the prior authorization team, we would have continued to have that error and continue to have that reduced payment. Denials due to medical necessity or prior authorizations really require that teamwork and collaboration between case management, utilization review, and the revenue cycle. So to address these challenges, we must align our teams around a shared mission. We must recognize that clinical and financial teams share the same goals, providing high quality, sustainable care. We must ensure that both teams understand the financial and clinical implications of the care and the decisions they make. We need to bring finance and clinical teams to the same table, use the same language, and discuss issues and create solutions. When clinical and financial teams collaborate, they can proactively address barriers like prior authorizations, optimizing swing bed utilization, and prevent contract-related revenue losses. This alignment improves care for patients while ensuring financial sustainability for the organization. Now I'm going to break down some of the clinical strategies, and then I will hand it off to Jen for the revenue cycle internal strategies. So the first clinical strategy is really admission status alignment, and it's a critical area where clinical and financial teams must work together. It's not just about meeting payer requirements. It's also about ensuring patients receive the right level of care while maximizing reimbursement for the hospital. On this slide, we broke down the distinction between observation and inpatient status. Observation care is expected to last less than 2 midnights. This also often involves monitoring and determining if the patient improves enough to go home or requires an admission stay. For example, administering IV fluids for a patient that was admitted with dehydration and observing if the dehydration resolves. Inpatient care is expected to last more than 2 midnights, involving active treatment from a medical problem requiring skilled medical professional care. And I think that active treatment is the key when we're looking at inpatient status. For instance, administering IV fluids for hypotension, assessing lab results, to treat worsening conditions like sepsis with IV antibiotics. It's more than observing. It's for the patients who will need that provider level of care, assessment, and change of plan of care to improve. But when we talk about admission status alignment, strong documentation is key to supporting that clinical case for admission. Providers must clearly articulate why that patient needs to be in the hospital, what they are monitoring and treating, whether that patient has failed outpatient treatment or has significant concerns requiring inpatient care. Are there any conditions that were present on admission? What are the patient's working diagnoses and the guide for the treatment plan? They also need to include all the comorbidities and the patient medications that really demonstrate the accurate complexity of that patient's case. Documentation is really the provider's train of thought, what they currently know, what they are doing about it, what they are watching for or concerned about, and what they are going to do if that happened. Strict payer denial protocols often lead clinical teams to adopt a conservative approach, categorizing patients under observation status even when they meet inpatient criteria. While this may reduce denials, it also results in substantial unrealized revenue due to lower reimbursement rates for observation. Medicare Advantage plans are now required to follow the 2-midnight benchmark as outlined, but they also require evidence of that medical necessity, which highlights the importance of robust documentation to justify admissions. Using tools like Interqual or Milliman's guidelines help strengthen admission decisions. These tools provide objective criteria to support the clinical rationale, ensuring admission alignment with payer expectations. Aligning admission status is about more than compliance. It's about balancing patient care with financial sustainability. By improving documentation and leveraging clinical tools, we can avoid denials, capture appropriate revenue, and ensure patients receive the care they need. So if you were at our regional meetings last year in Oklahoma, you heard me talk about provider documentation and the need for resources, education, and feedback. There is, at least in most medical schools and nurse practitioner schools and physician's assistant schools, no strong program that teaches you excellent documentation. It's a skill that is refined through continuous feedback and learning. And it really takes a team effort, such as a nurse saying during your interdisciplinary team meeting, I saw X comorbidity in the patient's record, and I see it's not addressed in your note. Is it something you want to add? Clinical documentation is really that cornerstone of accurate coding, billing, and ultimately revenue. But beyond that, it's essential for ensuring high quality patient care. And this slide really highlights the continuous improvement cycle that underpins effective clinical documentation. Improving clinical documentation isn't a one-time effort. It's a dynamic process that involves the following steps. It starts with assessing the current state of documentation practices. Are providers accurately and comprehensively documenting patient conditions, treatments, and progress? And then there's the feedback loops. By reviewing documentation against coding guidelines and payer requirements, we can identify gaps or areas for improvement, and constructive feedback empowers providers to make those necessary changes. It then revolves reflection, which is taking a step back to analyze that feedback. It's about understanding what worked, what didn't, and why. This step really lays that groundwork for actionable improvements. Then based on the reflection, we implement targeted interventions, whether through training, updates to documentation workflow, or leveraging clinical decision support systems at a level other than that utilization review nurse. With each iteration, the goal is to see tangible improvements in both quality of documentation and its impact on patient care and revenue. The cycle is more than just a process, it's a mindset. It ensures that teams are continually learning and adapting to change in payer requirements, regulations, and patient care needs. It's also a reminder that collaboration across clinical and revenue cycle team is critical. This not only ensures compliance and accurate reimbursement, but also enhances the overall quality of care. And what is more specific to Medicare authorizations than probably anything I will talk about is prior authorizations. So an efficient prior authorization process is critical to reducing claim denials and ensuring timely care for patients. According to the 2023 study by HFMA, Inefficient prior authorization processes and incorrect medical coding were identified as the leading cause of claims denials. With over 35 million prior authorization requests submitted in 2021 for Medicare Advantage plans alone, it's clear that mastering these steps is essential to reducing administrative burden and improving outcomes. So this slide demonstrates the key steps in the authorization process. The first step is creating a quick reference guide for your payers. This guide should outline your most frequent payers and where to find information about the benefits and requirements. This is important because it ensures that your team has instant access to the resources they need, reducing delays and minimizing errors caused by searching for information. Then there's the prior authorization requirements. We need to understand what procedures or stays require prior authorization. It's also important to know where to review the benefits and determine the necessity of a prior authorization and how to complete that prior authorization, whether that's by fax or an online portal, whatever mechanism that payer has set up. Sorry, I got quick happy. And then there's the timeliness. Every prior authorization has a time frame for completion. So knowing and adhering to the timelines is non-negotiable. Missing deadlines can result in delayed care for patients and lost revenue for your organization. We need to know these timelines and we need to hold strong accountability to the deadlines. It's also, as I talked about earlier, essential to ensure that prior authorizations are obtained for the correct level of care and service. Many times we see partial authorization. So, when we're doing outpatient exams, we may prior auth the CT of the chest, but we didn't prior auth the CT of the abdomen and the pelvis. So there's partial payment denial. So it's really essential that who's ever completing those prior authorizations understands that correct level of service and that all of the care that's being provided needs to be prior auth. And then there's documentation. Thorough documentation is the backbone of the prior authorization process, which includes regularly documenting clinical data to ensure the case is fully supported, keeping records of payer contracts, including names, dates, times, and reference numbers for when you were in contact with them, and including all required documentation for that prior authorization in the medical record for the billing department. Good documentation not only prevents denials, but also strengthens appeals when necessary. Then we need to track our denials. Tracking denials is key to improving our processes. We need to designate staff responsible for handling prior authorizations and ensure they are well trained. Proactively identifying and addressing denial reasons speeds up the resolution process and reduces the chance of those reoccurring. Finally, staying informed is critical. Signing up for payer newsletters helps your team keep up with changes in policies and requirements. This ensures that your processes are always aligned with the latest regulations, preventing unnecessary denials. Each of these steps builds on the other to create a streamlined and efficient prior authorization process. Remember here, the goal isn't just to manage the authorizations, but to master them, transforming challenges into opportunities for better outcomes. One of the most critical yet sometimes overlooked aspects of the authorizations and appeal process is the peer-to-peer review. This step allows providers to directly advocate for their patients by communicating with the payer's medical team. So when your utilization review team is not able to authorize your stay, that is when you need to set up this peer-to-peer review process. And let's talk about how to optimize this process and why it's so vital for both patient outcomes and facility success. So the first step in improving the peer-to-peer reviews is ensuring that providers understand the process. We need to educate them on when a peer-to-peer review is necessary, how to initiate one or who will be initiating this process, how will they be participating? Will they be receiving a phone call? Do they need to jump on a Zoom call? And then we need to educate them on the expectations of the process. This knowledge empowers providers to approach these discussions with confidence and clarity, increasing the likelihood of a successful outcome. Peer-to-peer reviews are not just procedural steps. They have a direct impact on both the patient and the facility. For patients, these reviews can mean timely access to care they need, avoiding delays caused by denials or authorization issues. For the facility, successful peer-to-peer interactions lead to fewer denials, better reimbursement, and strengthened payer relationships. Providers must see this as a step that is an essential part of advocating for their patients and supporting the organization. Ultimately, that's what a peer-to-peer review is all about. It's advocating for the patient. It's the opportunity for the provider to justify the care they are providing or they plan to give based on the clinical evidence and their professional expertise. Providers need to focus on presenting a clear and concise argument that emphasizes the medical necessity of the service or treatment. The goal is to ensure that the payer understands why this care is in the patient's best interest and aligns with their policies. Peer-to-peer reviews are a powerful tool when providers are educated on the process and understand its importance and approach it as an opportunity to advocate for their patients and explain the care in a further manner that maybe their written documentation didn't. So let's start by discussing some key findings related to Medicare Advantage denials. A data analysis conducted by KFF revealed that Advantage plans denied approximately 6%, or 2 million of the 35 million prior authorization requests submitted to them in 2021. While this number sounds alarming, what's more concerning is that only 11% of those denials were appealed. But here's what's encouraging to you as a facility. 82% of appeal denials were overturned. So this really highlights the significant opportunity to advocate for proper coverage through the appeals process, whether that be your peer-to-peer or submitting your appeal when your claim was denied. So there are two primary types of denials we encounter: the prior authorization or medical necessity denial that's received while the patient is still in the hospital, and then the denial that occurs after the claim has been billed. And each type requires a tailored approach. Despite the frustrations, you have a strong chance of winning Medicare Advantage appeals. Success hinges on reading the rules, taking timely action, and providing that adequate documentation. Persistence is key, as it is maintaining clear, factual, and comprehensive communication throughout the process. So let's break down this process into 3 critical stages as illustrated on this slide: identify, communicate, and appeal. So first, determine who's responsible for that prior authorization and ensuring proper documentation is in place. Identify who needs to be notified when we receive that denial. Who's setting up that peer-to-peer? We need to establish clear communication protocols for notifying others involved in the process. The next step is communicating to ensure the appropriate team is notified as soon as that denial is received. There are timelines and deadlines, so making sure everybody that needs to know is notified right away is so important in making sure we're timely. Setting up peer-to-peer reviews with providers can often lead to faster resolution and overturning of those prior authorization or medical necessity denials. And then there's the appeal. So it's a whole process in itself, but we need to understand those payers' appeal rights and review what is being denied. Is it a medical necessity denial? Is it a prior authorization denial? Is it a coding error denial? And then follow through with that entire appeal process, ensuring we meet every timeline and track our progress meticulously. We need to submit an organized, concise, and well-supported appeal with all the necessary clinical documentation. Winning appeal is not about just overturning a denial. It's about ensuring your patients get the care they deserve with a structured and organized approach as outlined here. You can navigate denials and appeals effectively, making a significant impact for both your patients and your organization. Managing denials effectively starts with understanding the data. Denials are not just numbers. They tell a story about potential gaps in processes, documentation, or communication. By identifying, tracking, and trending denial data, we can move beyond simply reacting to denials and start proactively managing denials. First, let's talk about identification. So on the left here, knowing the diagnosis and reasons behind denials allows us to pinpoint the root causes. For example, in 2024, we can see a variety of diagnoses with denials, such as COPD, CHF, and cellulitis. Identifying these trends highlights areas where we need to put focus, such as improving prior authorization workflows, provider education about clinical reasons for admission, or maybe clinical documentation workflows. The graph on the right is tracking and trending. How many denials have we had? What were the outcomes? How many do we have pending? It really tracks the system process as a whole, and it emphasizes the need for ongoing monitoring to catch patterns and address underlying causes. For instance, the high overturn rate suggests opportunities for better initial submissions, admission status alignment, or documentation, potentially reducing the need for appeals altogether. Finally, the ultimate goal of tracking and trending is really improvement. When we know which diagnoses are being denied the most, the outcomes of our appeals, and where delays or missteps occur in the process, we can implement targeted interventions like this, providing additional training to clinical and administrative teams, strengthening our peer-to-peer review process, or refining documentation standards. Denial data is really a powerful tool for you, but the key is to treat every denial as a learning opportunity to enhance your system. All of these components that we just talked about build a strong utilization review or utilization management program. It is not just a back office function. It's a strategic asset that bridges clinical care and financial success by ensuring proper admission status, streamlining prior authorizations, improving documentation, monitoring trends, and building stronger payer relationships. Your organization can effectively manage the complexity of Medicare Advantage plans while delivering high quality care. In rural healthcare, we often face unique staffing challenges where critical roles like utilization review. We're fortunate to have incredible nurses who are passionate about a patient care, and we frequently move them into these roles because of their clinical expertise. However, one of the most common mistakes we make is assuming that the clinical skills alone will translate into success in these highly specialized positions. Without proper education and ongoing support, we set them up for unnecessary struggle, and that's something we must work on. While great nurses bring a wealth of clinical knowledge, utilization review requires a very different skill set. This role demands an understanding of payer requirements, including Medicare Advantage plans, admission criteria and resources like interqual or Milliman's guidelines, complex documentation practices to support medical necessity, and prior authorization workflows and appeal processes. Without education and training, even the most skilled nurses can feel overwhelmed and underprepared. Resources are often limited, and staff members wear multiple hats in rural settings. This creates an environment where education and role-specific training can be overlooked. But the reality is this: when we don't invest in the education up front, we see increased denials, we see burnout, and we see turnover, all of which costs us more in the long run than providing proper support in the beginning. Education empowers nurses transitioning into that utilization review role to understand the why behind the processes they follow. And when we understand the why, we know what happens when we don't do them, what the impact is downstream. It allows them to communicate effectively with payers, providers, and leadership, and advocate confidently for patients and the facility during peer-to-peer reviews or appeals. Support isn't just about training, it's about ongoing mentorship, access to resources, and creating a culture where questions and learning are encouraged. We must recognize that moving a great nurse into a utilization review without proper education is like handing them a tool without instructions. I'm now going to pass you over to Jen so she can walk through the internal revenue cycle strategies.
Thank you, Nicole. So the first thing that we want to talk about today is our Medicare Advantage contracts and how to go about reviewing those, and of course the negotiations. Medicare Advantage contracts can drastically impact hospital revenue through reimbursement rates and bonuses for quality performance. Securing positive reimbursement rates is crucial for maintaining financial stability and ensuring the hospital can continue to provide high quality care. Successful negotiation with Medicare Advantage plans requires a deep understanding of market benchmarks and a clear demonstration of your value. When preparing for contract negotiations, it is important to know your value. More specifically, how does your organization perform in terms of patient outcomes, quality metrics, and cost efficiencies? What specialized services are offered that will add value and justify higher reimbursement rates? You want to highlight the hospital's commitment to high quality patient care, including metrics such as low readmission rates, high patient satisfaction scores, and adherence to clinical guidelines. An example of this would be stating, our hospital consistently achieves excellent patient outcomes, as evidenced by our low readmission rates and high patient satisfaction scores. This commitment to quality care is a key proposition in our negotiations with your Medicare Advantage plans. Contract negotiations should also identify and emphasize specialized services or centers of excellence, such as advanced cardiac care, orthopedics, oncology, or unique programs like rehabilitation or geriatric care. An example of this would be to state our hospital provides specialized services, including our state-of-the-art cardiac care center and comprehensive oncology program. These specialized services add significant value to our contracts with your Medicare Advantage plan. You should also emphasize the hospital's role in the community, including community outreach programs, partnerships, and contributions to public health. An example of this would be to state our hospital plays a vital role in the community, offering numerous outreach programs and partnerships that enhance public health. Our commitment to the community is a testament to the value we bring to your Medicare Advantage plan. You must also know where your organization stands financially. Performing a thorough analysis of your direct and indirect costs. An example of this would be your overhead and your staffing expense. You should also compare your cost and reimbursement rates with other facilities to understand where you stand in the market. Showcase the hospital's financial health and stability, including successful management of resources and cost containment efforts. Use data and metrics to provide concrete evidence of the hospital's performance, efficiency, and value. An example of this would be to state our hospital's financial stability and effective resource management makes us a reliable partner. We have a proven track record of cost containment and efficient operations, ensuring that we deliver value while maintaining financial health. Our performance metrics speaks for themselves. We have demonstrated efficiency and value through data-driven evidence, making us a valuable partner for your Medicare Advantage plan. Emphasize the importance of building strong relationships with payers to achieve mutually beneficial outcomes. Make sure the payer understands you want to build a relationship with them. When preparing for negotiations, include statements such as, by working together, we can achieve mutually beneficial outcomes that enhance patient care and optimize reimbursement. Next slide, please, Nicole. Effective reimbursement. So the capitated payment model of Medicare Advantage plans means that hospitals need to focus on providing high quality care while managing costs effectively. Understanding how these payments are calculated will allow you to optimize your revenue cycle. Proper coding and documentation are the backbone of effective reimbursement. Ensuring that your clinical staff are well trained in accurate encoding practices will prevent revenue loss and avoid potential penalties. Denial management plays a critical role in helping hospitals maintain effective reimbursement with Medicare Advantage plans. Denial management helps identify and address the reasons behind claim denials, reducing revenue loss caused by unpaid claims. This also leads to our next topic. Proper denial management ensures that hospitals comply with CMS guidelines and payer policies, reducing the risk of compliance issues and penalties. Compliance with regulations is essential for maintaining a positive relationship with payers and avoiding financial penalties. Next slide, please, Nicole. So again, we talk about our admission status alignment. Properly determining whether a patient should be admitted as inpatient or placed under observation status is critical for appropriate billing and reimbursement. Misclassification can lead to revenue loss, as inpatient admissions generally result in higher payments from Medicare and other payers compared to observation status. Ensuring accurate admission status alignment helps maximize reimbursement and avoid potential denials and underpayments. To ensure appropriate reimbursement, key steps include providing comprehensive training to staff on criteria for inpatient versus observation status, and implementing a robust utilization review process to verify the accuracy of admission status based on established clinical criteria. You should also schedule regular meetings between clinical staff, case managers, and the revenue cycle team to discuss patient cases and ensure consistent documentation and address and resolve discrepancies in admission statuses. You should also implement CDI programs to enhance accuracy and completion of medical records. Encourage real-time documentation practice to capture accurate information at the point of care. Lastly, you should track KPIs related to admission statuses, such as observation to inpatient conversion rates, to ensure alignment with reimbursement requirements. Proper admission status alignment contributes to the overall financial health of the hospital by optimizing revenue and reducing the risk of revenue loss. Accurate status determination ensures that the hospital receives appropriate compensation for the care provided, supporting financial sustainability. Streamlining admission status processes can also improve operational efficiency and reduce administrative burden. Efficient processes minimize errors, reduce claim denials, and enhance the overall efficiency of the revenue cycle. Next slide, please. Oh, we're at the end.
So if anyone have any questions, we'd be glad to take them now.
I just wanted to note that you can unmute your line or feel free to put something in the chat.
Our contact information is also on this last slide. So if you think of something later, you can always reach out to us directly also.
We have a question that came up in the chat. Sorry, I have too many windows open. Do they not pay like Medicare? And then also recommendations for clinical documentation and education resources.
Okay, Jen, I will let you or John respond to why they do not pay like Medicare.
So I believe it's because of the fact that they have different contracts with CMS. It all ties back to that contract. What they pay is according to contract, and of course, it's a line of business. So they're looking to make the most money out of their contract just as much as the organization is looking to make the most money for the reimbursement of care provided.
And Jennifer, before we get to Lane's question of education resources, Misty Kirk had a follow-up. I feel like it kind of follows this one. Do they not have to follow Medicare rules and have a year for timely filing?
They do not. That is one of the downfalls for sure. CMS allows them to renegotiate contracts with CMS as well and establish their own timely filing requirements.
All right, and then Jennifer or Nicole, do you have recommendations for documentation education resources?
I think the practice that I've seen work the best outside of, somebody coming in and providing education is really that peer review practice of having a couple providers review each other's documentations, giving them maybe documentation from a patient they documented on a year ago and, look at it and say, okay, what does this documentation show you? Does it tell the story you want it to tell? And then the other is just really that real-time documentation of, we have Sally on the floor and she has all of this going on and we know that because we're communicating it as a team, but does that documentation reflect that information? It's that continuous learning, review, and reflection that really builds those practices. When you're talking about specific resources, if you're seeing a specific trend with a specific denial, maybe you're seeing urinary tract infections that are always getting denied, building those documentation workflows. What is it that that payer wants for that admission status, and building that workflow into the documentation to ensure the providers put it in on admission.
All right, are there any other questions? Any future plans for webinars on prior authorization process? Not at this moment, but I will say, actually at 1:00 today, we do have a revenue cycle networking monthly meeting, and actually it kicks off here in a few minutes. And it's more of a networking amongst other clinics and other hospitals here in Oklahoma. Largely, the topic has been around moving towards the Medicaid managed care, but we do have talks on that call as well for prior authorization. But let me look into additional resources along these lines. Are there any other questions? Okay. One quick announcement. This series was part of our kind of follow-up to the pre-conference session that we hosted in October at the Rural Health Conference. Our next session was originally scheduled for February 12th, and the topic for that one is benefits Oklahoma employee investment benchmarks. I will be out of state during that one, and so we've rescheduled it to February 5th. So after this call, I will be sending out a reminder for that call. If you've already registered for it, you should have received updated connection information. If you haven't registered yet, and I will be sending that link out, you will get the correct connection information and date. So if there are any other questions for this call, please either come off mute or put them in the chat. And if you get off of this call, or if you're watching this recording and have any questions that come up, please do not hesitate to reach out. All right. Well, I'm not seeing anything. So thank you, Nicole, Jennifer, and John. Thank you all for your time today.
Thank you for having us.
Thank you, everyone.
You all have a great rest of your day.
Thank you.
Thanks. All right.
Bye.
Bye, everyone.